Hello, good
Hi,
evening, everyone.
Dr. Navity.
Dr. John Santa Anna, welcome to our evening webinar for the month of November, just before the Thanksgiving holiday. So before we get going, everyone have a happy Thanksgiving and be safe. So we kind of wanted to do this webinar to kind of talk about different treatments, newer treatments that we offer here now at the Michigan Center for Regenerative Medicine. One of the things that Dr. Navi and I pride in is that we want to be, side by side and in step with everyone in the field of regenerative medicine, is to make sure that we offer the most advanced and best treatments that's available, that's backed by data for all our patients that we see here. So, and I'm glad to say that there's more things that we're able to offer now.
Yeah, this is a very quickly evolving field. Both John and I spend a good amount of time keep them up to date with our societal recommendations, different literature, and maybe not being the absolute first to implement a new potential technology. But once that shows promise and safety, with safety being number one, we're pretty quickly to include things into our practice and treatment options for our patients. So I guess kind of without further ado, we got a whole list of topics we wanted to briefly talk about tonight. So if you got the first one.
So the first one, we've kind of talked about this before, is the intraosseous bone marrow stem cell injections we've done for our patients. So for our patients with severe osteoarthritis in the knees, the hips, and the shoulders, where we see, grade 3 and up KL scores, those with signs of subchondral edema, which means there's swelling in the bone surface, things like that. I think this is a great option for it, because in addition to just injecting stem cells into the joint itself, we're able to inject the stem cells into the bone that's adjacent to the cartilage that helps nourish it better.
Yep.
Right?
So if it's that much better, why wouldn't everybody start doing this?
That's a good point, right? Because I think it's because it's technically difficult, right? It adds that layer of difficulty onto the procedure. There's more newer equipment and tools involved, and I think that's it. It's like it's this other extra step. And to your point, if it's that good and it makes sense to do it, why not offer it to everyone? And yeah, I guess there's no reason why not to.
And why it's easier for John and I to kind of make that and flip that switch is we really have built a facility that allows us to very quickly implement these types of new technologies. We have the necessary equipment. What do you need to do an intraosseous injection? Is a fluoroscopy machine, and you need anesthesia. We have both of those things on a regular basis here already, whereas a lot of regenerative medicine clinics are strictly doing stuff either solely by ultrasound guidance or by, terribly, I hate to say it, that there are still some clinics out there strictly doing by palpation guidance, meaning with their hands. And regardless how good they think you are, you can't safely guide a needle nonetheless into an ACL or into a meniscus. Now, if you're going to drive it into the bone, you certainly need that assistance of an X-ray machine. And while it's not as nearly as painful as I think either of us expected it to be for our patients, it is still something that given the technical skill that's necessary, the patient really needs to be remaining still. And the best way to secure that somebody's remaining still is to have the advantage of having anesthesia available to do these procedures while people are sedated.
Yeah, so the less we have to worry about the patient's state, when doing this procedure, then I could just focus on addressing the task, which is, addressing that bone. And again, to Dr. Nabi's point, so a lot of times when we do these IO procedures, we utilize both X-ray, which is fluoroscopy, and ultrasound, because, you want to be able to map out nerves and vessels too before you drive something in that area. So it's, again, number of priorities, safety. And I think because of that, we're able to kind of offer more of our patients and do these better.
Then the other, I would say, reason why we're able to pretty quickly implement that, one of the advantages of our lab is we can process more volume than most clinics who do these are able to process, meaning that when we're putting your bone marrow, your blood into our regenerative lab, we were able to get a higher volume of your bone marrow blood processed, which then nets us a higher volume. We go to re-inject it. When you're doing these intraosseous injections, you need a relatively large volume of really high quality bone marrow concentrate, also known as stem cell, or really high quality platelet-rich plasma. And if you're not manually processing those things, if you're using the bedside centrifuges, at best, you're probably going to get 2 to 6, maybe milliliters. Whereas when we're doing a bone marrow procedure, we'll get 12 to 14 milliliters, which gives us that extra volume to treat additional structures, as well as get that good spread inside the bone marrow when we're doing the intraosseous injection.
Yeah. So yeah, I think so. I think now we're deciding to change our approach to this.
In the last month, I mean, we just did a webinar last month about it, and now, it just as you alluded to, is initially it was really just for my bone-on-bone, really real severe ones, patients, and now why not? Why not do it to everybody? Absolutely. It works that much better. We're really starting to increase that selection criteria for who can benefit for something like this.
Yeah,
it's really not that much more painful when done with the right sedation, with the right local anesthetic, it's not that much more risky when you're using the right tools and the right hands, and the outcomes are that much better. Yeah,
there's no the downsides are exactly the same. There's the downtime is exactly the same, and your limitations are exactly the same. It's a longer procedure for us. It's an added extra step that we have to do, but
correct.
If the outcomes are that much better, then why not?
Correct. And those are the fun questions we get to ask and talk about with our patients. And we don't have to ask that uncomfortable third person that's not in the room, their insurance company, that can we do this, right? This is a nice conversation we just get to have with our patients on what we think is best for them, what kind of outcome they're looking to get, and then we make a recommendation and we go.
Yep.
Topic number 2.
Topic number 2 is adipose stem cells, or what we call is micronized fat adipose tissue.
Yeah. Yep.
So MFAT is what it is. So essentially, it's a newer treatment that we're implementing here. I know over the past few years, patients are very well-versed patients ask us about when are we going to start using adipose stem cells over bone marrow stem cells for one reason, more other reasons here and there. But now, I want to say that we're offering MFAT adipose stem cells for our patients. The data on adipose tissue looks very promising with shoulders and knees. The other advantages that we see there too is just the ease of harvest. The joke is that there's always fat to harvest. There's never a lack of it. So and then you get a little bit of a liposuction with it. It's just not cosmetic, but
nor do I want to claim that I know how to get a great cosmetic result. But.
But it's one of these treatments where you get quality of outcomes from bone marrow by using adipose stem cells, but you have this easier extraction than bone marrow stem cells. There is still some applications where I think bone marrow is still a better option than fat. Right now, from what we see on the data that's being published, is that it's as good as bone marrow, at least with shoulders and knees. So I think the more data comes out with that, then we'll probably start implementing it more and adjusting our range.
Yeah, so I'm still a little hesitant on fat being better than bone marrow. In my opinion, right now, I'm still leaning more towards bone marrow being essentially what the body's natural source of these cells is, where they're manufactured, the fat being where they're stored. It is a bit of a numbers game. The most difficult thing for me using fat is I can't quantify it. There's no quantification system yet for me to quantify how many cells am I getting out of the fat. So it takes me a little bit back to when we first started doing regenerative medicine, and I was using one of those bedside centrifuges and wasn't using a quantification system. After I push a button, or in this case, you're pulling it through a filter, and you're going to inject it, you're left wondering what's in my syringe. I don't know exactly what's in it. So I'm thinking there's nothing bad in there. It's going to be additive to whatever we're doing. So a lot of what I'm looking at using MFAT for is adding on to a PRP or adding on to a bone marrow concentrate procedure, where at least I know a baseline quantification what I have, and then I'm adding more. At best or at worst, I'm adding more scaffold, something that's going to help build those tissues, and probably a whole bunch of more cells. That's really what the limited data that looks at cells shows, is that the type of stem cells we want with connective tissue are called mesenchymal stem cells, or MSCs, and there appears to be a higher concentration of MSCs in the same equal volume of fat versus bone marrow. Now the question is, are MSCs the most important, or the only ingredient that's necessary or important in that regenerative soup? My guess is probably not. There's a lot of other important ingredients, and mimicking the body and going to where it's manufactured maybe makes the most sense for me. But boy, I'm excited to start offering this and having it as an option for folks, especially as these as this more data comes out. And again, how hard was it for us to flip that switch to add fat? It wasn't. We've already done the training. We already knew how to do the aspiration. It was a matter of buying some additional equipment, which we purchased, and now have those tools to do a safe, effective lipoaspirate technique. And boy, we can combine it with PRP. We can combine it with bone marrow. And then when it comes to re-injecting it, it's the same technique. And both of us are very skilled at getting needles into the areas that need this regenerative help.
Yeah. So I'm kind of with you. So like I like seeing this fat as adding more of a scaffold or another, like for severe degeneration and in shoulders and stuff like that. I think it makes sense to use it. And ease of use. Like a lot of patients, when they hear, we have to get into the bone to get into your bone marrow, just the sound of it is painful, which it is. It can be uncomfortable. It's not terrible, but it can be uncomfortable. Lipoaspiration from your belly is very well tolerated. You don't need sedation for that. And so that's, there's pros and cons to all of these things. And just having these options presented to patients, I think, is one of the nice advantages of coming here.
Yeah, I always said lipoaspirate is a great marketing. You're doing a seminar, and how many of you want me to take your fat out? And everybody raises their hand.
Yeah.
How many of you want me to do a bone marrow aspiration? And nobody raises their hand. So it is a much easier sell from a patient standpoint of the source. Obviously, the reason you're doing this is for the outcome, and more to come on that. We'll talk tonight about tracking our outcomes and being able to answer these questions in a moving forward timeline.
Okay. Yeah, and I think you kind of hit it on earlier too, like with the MSCs and parasites and also and possibly other ingredients in what we inject into. The next topic that we have is the super shot PRP.
Yeah. So there's a company I work very closely with. All disclosures aside, I'm the chief medical officer of that company. So I've been working closely with a company called Forever Labs, and their chief science officer and other team members have come up with a technique for isolating what are called extracellular vesicles, or exosomes. So there's a lot of buzz about exosomes in the regenerative world. It is essentially a signal that one cell sends to another. And one of those things and one of those types of exosomes has messenger RNA, which is the thing that it's the signal that an MSC, mesenchymal stem cell, will send to other cells to tell them to grow and divide. So that's the signal that these stem cells essentially emit. And the theory is if you can isolate these exosomes, maybe we don't need stem cells at all. Maybe we just need the signal. And so there are these purely exosomal products that are out there that are being tested. But all of them are what are called allogenic. They're coming from a donor, not from you. So what Forever Labs was able to do is find a way to, at the point of treatment on site with standard centrifuge speeds, isolate the extracellular vesicles that are in your plasma. So they have a patented, protected mechanism for doing that. And essentially, you can take it and add it back to your PRP procedure or your bone marrow concentrate stem cell procedure and create a theoretically better PRP or a better bone marrow concentrate. So the term that's been, or the trade name that's been developed for this product is something called super shot, because it's super PRP or super bone marrow concentration stem cell procedures. Currently being marketed as an add-on for any system that creates PRP or any system that creates bone marrow concentrate. And it's one of the things we've implemented here. So I've been doing it for over a year now and adding it to a multitude of my PRP and bone marrow concentrate procedures. And anecdotally, strictly anecdotally, I can tell that, or it seems to appear to create a faster recovery. And we'll see if it's a stronger recovery by tracking these data and tracking these outcomes through a central registry that hopefully will prove whether it's a value-added service or whether the standard PRP or standard bone marrow concentrate is good enough on its own.
Yeah. So this, so I don't use Super Shot. I think it's one of those things where I'm kind of waiting to see more out of it. So I think in a way, since we're both coming up with similar techniques, similar patients here in this clinic, it's a way of kind of looking at, I'm kind of acting as control, I guess. Like when I do my patients, I just use the regular, classic PRP, and it's still good outcomes there. So it's, I think it'll be good to see, like with the registry, kind of, how much of an improvement would be with the Super Shot. Is it worth the added step, added expense, and all that stuff with that too? So, so I think it's exciting in regenerative medicine because we're comparing good things to other good things, and hopefully come out to be great things.
Yeah. There's a ton of different apple pie recipes out there, right? I mean, what's the one that actually tastes the best, right? Yeah. So those are the sorts of we're really getting kind of down to the nitty gritty of what are the most important ingredients in that recipe that's going to get our patients the best possible outcomes. I love that we're in an environment where we're able to kind of trial and error a little bit within the safety of number one. We're not going to do anything that's risky. We're not going to do anything that's going to potentially add a significant amount of risk to your procedure from something that we know is already working well.
Yeah. Good. So the next one that we implement here, I've been implementing it a while now here, but we haven't really talked about it much, is this idea of using platelet lysate for epidural injections. So, for people who are not familiar with that term, platelet lysate is essentially a PRP preparation where we strip the platelets and essentially just take the growth factors and all the stuff inside the platelets that are active in doing regenerative medicine, and that's what we use for injecting into the epidural space in your spine for somebody who has radiculopathies and herniations and things like that, and even doing hydrodissection techniques for carpal tunnel or tarsal tunnel syndrome, like any type of nerve and neuropathy issues. It's been shown to kind of been helpful for that too. So and there's a lot of data that shows that platelet lysate is better than doing repetitive epidural injections, because it's the same epidural injection technique, but instead of injecting a steroid in there, which temporarily is an anti-inflammatory, the platelet lysate actually controls inflammation much longer and has better relief that way with some curative properties too. So I think that's another aspect of being here in MCFRM, is that we kind of make these adjustments on the fly. And, for somebody that comes in who has good results from epidural injections and, except that it's temporary and we have to continue doing these injections, we could offer a platelet lysate as an alternative where, instead of getting, 6 to 7 epidural steroid injections a year, maybe it'll just take 2 or 3 platelet lysate injections, and then done, and then you're good. So there's data that shows that there's outcomes that are like that, and that's the exciting part. And you may not need the whole lumbar or cervical treatment where we treat the facet joints and the spines, and all it takes is that one injection. So again, another option that we offer here. Everything that we do here is tailor-made to you. So it's when patients come in and ask questions like, how much is this procedure? How much is this procedure? Well, it all depends, because, we don't really have a carte blanche, I guess, treatment menu. We have a certain degree of idea of kind of what to do, but, we kind of take pieces of this and pieces of that and kind of making it work for whatever is going to be best for patients. So.
And one of the benefits you get from coming to our clinic is you don't just get one great mind, you get 2 that don't think identically. I was late to the, I think, platelet lysate game. I credit Dr. Santana for kind of bringing me into that fold and really opening my eyes to, wow, these injections really are good for nerves. It's not just cortisone in a regenerative package. It actually works differently than cortisone works. It provides that immediate relief, or that soothing relief that you get with cortisone by lysing those platelets and getting that immediate relief. But it also stimulates a growth and a healing. Where and exactly how that fits into our patients, I think just depends on where their nerve damage is. Is it a chronic nerve damage? Is it an ongoing nerve damage? But things, again, we're figuring it out as we go. And having a partner that is going through this journey with me makes me a better doc. I mean, it brings out things that otherwise I probably wouldn't have brought as heavily into the practice as we have. So I appreciate having such a great partner to be able to do this with.
I think you're right. I mean, because one of the things that allows us to evolve faster than most is that because I can bounce off ideas off of you, and then I trust your clinical judgment and your expertise in everything. So when I bounce it off of you, you tell me, "Oh, that's ridiculous. That's not." You never say that, but I mean, you would if it is. But but in the same breath too, like, oh yeah, that actually does make sense. Like, what if you do it this way instead? And so it's you're right. It's like we're bouncing ideas off each other, and I think it makes us evolve much faster and adapt things easier here in our clinic. Because we're in that same mindset. Hey, let's do whatever's going to be best for everyone.
Yeah, we don't have a box that we try to fit all our patients into, and we have very open minds about incorporating things with safety as number one. As long as we can, can justify that what we're going to do is going to be safe. We try a lot of new things here, and have found a lot of things that work. That's what's so fun about this field is there's a lot of things out there, and finding the exact right recipe to get our patients the best possible outcome is still something we're striving for every day. And the next topic I have is I don't know if you guys know, but we actually also do cosmetic procedures here. Primarily, it's hair regrowth and hair regeneration with the use of PRP. So our clinical nurse, Tina Polich, she is well versed in doing regenerative treatments for hair loss, and she's been doing it now for as long as we've been around, since 4 years now, and she's compiled a whole slew of pictures and outcomes from day one till end of treatment on how hair PRP works really well for regrowing hair. You know, it's definitely a huge market that just keeps getting bigger, and for the most part, most of the patients that we've treated are patients that we're treating their shoulder, we're treating their knee. Oh, by the way, we have some leftover PRP you want us to put in your hair. And wow, is it not working really well? We've decided that we want to try to start getting that word out. Just like orthopedics, getting a good outcome from a hair PRP starts with what are you injecting? And the quality of the PRP matters. We have great PRP here at Michigan Center of Regenerative Medicine that we're, for the most part, focusing on orthopedic issues with, but there's no reason we can't regenerate hair. That injection technique is easy. The scalp is almost impossible to miss. You just have to get the needle under the,
especially when you have a lot of hair. It's really hard to miss.
Combining that with topical anesthetics and local blocks can make that a lot more tolerable. So it doesn't have to be a painful procedure. This one, unlike orthopedics, where it's usually a one shot and done sort of thing, just like when you're getting hair removal, hair follicles grow in cycles. And so that's why you can't just go in for laser hair removal once and lose all your hair and never have to go back in. You have to get each follicle when it's in its cycle. Just like PRP, you got to stimulate that follicle when it's in its growth cycle. So it usually takes 3 to 5 procedures separated about a month to 6 weeks apart, but the outcomes are incredible. And so if you have somebody that wants to regenerate some of their hair, that's something we can help out with. And boy, if you're thinking about doing hair and you have a shoulder issue, we can do both at the same time.
And I think before too, my own kind of stereotypes and biases, I thought that mostly men are the ones who are gonna be using hair PRP, but you know what, we get a good number of women here too, and and knowing more now is that it's probably harder for women to have issues with hair loss and alopecia because, with men, if you lose your hair, you can shave it, and that's socially acceptable.
Correct.
But for women, that's a lot of times it's not an option. So we're offering it here. Like I said, we do the same high quality PRP as we would use a PRP for any other orthopedic condition here. So we want to make sure we get the best high quality stuff for you to use. The next topic we have is the SAM X1. Here it is.
So this it's a device that we were introduced to. Love the science behind it. Therapeutic ultrasound, so not diagnostic ultrasound, but a therapeutic ultrasound machine that provides an ultrasound wave of energy. Gets absorbed at muscle-bone interface, so primarily tendons, but can help with stimulating growth and healing of muscles, potentially ligaments as well. Not indicated really for osteoarthritis, but it's one of the things that we've had a lot of success with our patients that are coming in, and maybe they have a little tendinosis, which isn't quite a tear, but it's not an acute just inflammation of their tendon. It's something that's going on a long time. They're not quite ready to invest in the PRP treatment and the downtime that's involved with the treatment and the taking time off from their sport. This is something that can be used in season, and it can be used every day. You can put it on. It's a wearable device. It's portable. You plug it in, and it delivers this energy over a 1 to 4 hour period, and it provides essentially similar growth factors by use of ultrasound that PRP does.
So it helps facilitate remodeling of the tissue. So it's kind of what we want to achieve with regenerative medicine, with PRPs, to remodel that tissue to heal it. It helps improve blood flow into the area too. So with increased blood flow, you're attracting more growth factors and healing factors into that tissue. And we know that ligaments and tendons have very poor vascularity, and inducing more blood flow in the area does kind of help with the healing as well. And in the same way, it kind of drives more nutrition in there. You get the joint, the ligament, the tendon gets more nourishment because of that. So it kind of does go hand in hand with kind of what we do here. So we're kind of like thinking of the idea. I think in the best case scenario is, yes, you can use this device on your everyday basis, while you have like a minor injury or something like that. But I think even our post-procedure patients, we've done like a PRP or a bone marrow or a stem cell or something like that, is to use this device along with your healing after the procedure to hypercharge that healing process, get more, attract more cells in there, improve that remodeling phase, improve that healing. Maybe the outcomes will be better. It sounds like it is just going to improve and build on what we already put in there.
Yeah, it's about stacking. A lot of buzzword of stacking therapies. This is essentially stacking therapy, and we got to be careful because there's so many things out there. There's hyperbaric oxygen, there's ozone therapy. At what point do you say that's probably overkill? You're wasting your time, you're wasting your money, versus, hey, this is a good value. Right now, I think we're both in the camp that before a bone marrow procedure, taking supplements makes a difference. We've done stem cell counts. We see cell counts go up with specific supplements, and we recommend those. I think this is going to be something that pretty quickly, I personally used it. It was amazing. It worked really, really well. I've treated a handful of patients that just weren't quite ready for the PRP, and darn if they didn't get better, and now they don't need their PRP. So it's great, right? Finding the simplest solution for people, but for those folks that have a more severe problem, we do the PRP. It's helping, and now instead of maybe doing a second PRP, what if we throw this on top of that? We're stacking the therapy and trying to get everybody the best outcome they can as quickly as possible, and we're doing everything we can to kind of peruse through these different technologies to hopefully find the ones that are best for you.
It's kind of nice too, because it's invisible. Like you put it on, you forgot it's even on there, and it's working to treat your ligaments in your tendons, and it helped me in my Achilles, and you forgot it's there. You just go through your day like, I have this thing on me, and then you forget that it actually worked. I didn't even notice any pain in my joint the whole time I was kind of going through my day. So it's nice because it's very discreet. It has a very low profile, easy to use. So it's one of the nice additions we have here, and it's available, and we can talk more about it, in the office too. Let's see. And then I guess to cap it off, we just want to, I know for a lot of our patients and we've done talks about this too, is we've talked about data biologics. So for a lot of our patients, these are one of the things that we like to talk about with how we're helping the field of regenerative medicine forward. And with their help, we're able to compile this data on this registry where our numbers are being tracked, patient outcomes are being tracked over a span of time to see how well our clinics stack up to other clinics, how well our procedures stack up to, if one treatment protocol is better than the other. It kind of gives us this data, this more information to kind of glean over and see.
I think the most powerful thing that we can do in a consult is not just look somebody in the eye and say, hey, take my word for it, this is going to help you. We can actually log on and say, okay, here's people just like you who had this treatment that I'm recommending, and here's the outcomes they had. Well, what about this treatment? I don't know. Just like typing in any search engine, let's look. Oh, well, if you did bone marrow, it looks like it's an 85% outcome. If you did fat, it's a 90% outcome. If you did PRP, it's a 60% outcome. Boy, I want to do fat. Well, you actually have real data, and that's about to be right at our fingertips with this platform. They have a search engine that takes all of those different variables and then tracks those outcomes over time. And our patients have been great about participating with this. It takes patient participation. We need patients to fill out surveys, essentially looking for pain levels, function levels, and adverse outcomes. So we can make educated, data-driven decisions on what we can do about your pain, what we can do about your function, and how can we avoid anything bad happening, any negative outcomes. It's a really powerful tool. It's about to be at any regenerative medicine doctor's fingertips that want to subscribe and utilize this platform. We've been using it for almost 2 years.
Yeah, maybe more.
I think we were live December of 2020. So I think we're right at 2 years, and getting that long-term data, so we don't just see how patients are doing at 1 month, 3 months, or 6 months, but we got 2-year data coming now, where we can see sustained relief of pain, sustained improvement in function, and again, that people are avoiding any kind of complications and avoiding surgery.
Yeah, and that question I get from patients is like, it's going to do this and that's going to work, but for how long, right? Now we can tell you, we can tell you how long it's going to work, as we march on with this data and collecting more data. So, so I want to give a big thank you to all our patients who agreed and to join the data biologics registry and put their data on there. You guys are definitely moving this field forward with your help. So.
Yep. Yeah. We love our patients. We really appreciate you all. Word of mouth has become a huge referral source for us, and we couldn't do it without you. Time for some questions. All right.
Yeah.
All right. Let me lean over here. So I got one. Do you need a larger volume of the fat cells in relation to the bone marrow? It's a great question.
Great question. So from what we do know, comparing bone marrow stem cells and fat stem cells, is that there's more stem cells per volume of fat than there are in your bone marrow stem cells, because the idea is you have more pericytes in the fat, so you get more of that. If that's the case, yes, you can argue that you need lesser volume of adipose than bone marrow to get a similar outcome. But in the other sense too, if you use the same volume, then you're having more units of stem cells in that volume. So it depends, right? So again, what are we trying to accomplish and things like that? And I think until there's a better way to quantify that fat sample, right? That part we're still not clear with, as far as how do we completely quantify this sample here and comparing it to what we know with the bone marrow sample. Right now, we're able to sample your bone marrow and tell you exactly what's in it, but the fat, we're not at that phase yet. So, but from data, it shows that there's more.
Yeah, the company who runs our lab, Gray Ledge Technologies, is working hard at just that, trying to find out a way to get point of care quantification of fat. In the meantime, it's just going to be based on volume. The nice thing is we have this data tracking system that we can hopefully at least correlate volume injected to outcomes.
Yep.
It'd be great once we can quantify that volume and we can get dose to outcomes.
Yep.
Another question coming in. What was the device called again? So I'm assuming we're talking about this one here. It's called the SAM X1. I don't know if it's prescription only or if it's something that anybody can go out and find and get. We retail it here in the office. If anyone's interested in trying one out, we'll do trials. So you can see if it helps you before buying it. And we haven't had anybody that hasn't worked for it yet. So
so far everyone's tried it, likes it,
and
they want it, because you might buy it for your elbow today, but 5 months from now, hey, you know what, my shoulder needs it, or something else. So and you could always use it for any other parts.
All right, we got one coming in. Do you have anything to treat nerve damage? I've been told I have neuropathy in both legs and my feet.
So that's a tough one. So I think one of the advantages of having me and Dr. Nabi here in our experience in sports medicine, pain management, and interventional orthopedics is that we're really good diagnosticians. And that's the secret sauce in everything that we do, is like we are good at figuring out what is causing your problem. And that when we know it, then we can treat it. We have a panel of treatments for that. With neuropathy, that's a little bit difficult because neuropathy can be caused by a whole lot of things. So it could be genetic, it could be nutrition, it could be systemic. So there's a lot of things. Now, if the neuropathy is from an impingement, like an anatomical or mechanical impingement, there's something we can do with that. We can relieve the impingement. We can treat the nerve that's in that area that's being pinched. That's one way. But if it's outside of that, then it gets a little difficult, and that's kind of where medicine kind of becomes art a little bit. But if it is neuropathy, let's say from diabetes or radiation or whatever reason from the feet, there's a lot of other treatments that we do here that may not be regenerative medicine related, but still addresses the neuropathy with, peripheral nerve stimulation, spinal cord stimulation. These are implantable devices that we put in either the spine or in the extremities, where we're able to control the nerve signals that are signaling for pain. So it's an office-based procedure. It works very well for diabetic neuropathy and all these other neuropathies that affects the lower extremities, or even just nerve pain from different areas, from injuries or whatnot. So there's that option too. So it's so it depends on, the answer is, again, depends on kind of where it is and what's coming from. But we have options at least to present to you, whether it be regenerative medicine options or a stimulator option.
So how, I'll let you get a plug for your testing here, but how would you decide if somebody's coming in and they say they have neuropathy? What would be the first things you might do to try to determine what type of neuropathy?
So one of the things that we do here is we do an electrodiagnostic study. So, or a lot of people would kind of call it an EMG or electromyography. So essentially it's a two-part test where we can test how the health of your nerves are. So it tells us how well your nerves are functioning. It tells us if you have a nerve injury, where's the nerve injury located? And then the third thing it tells us is how severe is the injury. So between those things, we're able to really figure out how to treat it because we know kind of what the problem is. There's some nerve injuries that are just really tricky, right? So, but the nerve study, the EMG, kind of helps us narrow down this big differential diagnosis to something that kind of would make sense. Because you may have some neuropathy in your feet, but maybe coming from your spine after all. And then the EMG helps us kind of figure that out.
So it was described to me in my residency as a thinking man's test. And this guy is probably one of the best electromyographers I've ever met. So if you do have a nerve problem and nobody's been able to tell you what it's coming from or why you have it, I suggest getting an EMG. And if you're close, get one from this guy.
Yeah, thank you.
Yeah. I think we probably exceeded what we normally do. This was a great topic. I really liked tonight's discussion. It was very filled with a lot of information. So if you all have any questions coming out of this, if you want to see if we can help you with the condition you might have, please give us a call, 248-216-1008. You can visit our website. You can fill out a form online, the regenerativemedicinemichigan.com. And Dr. Tom Nabity.
Dr. John Santa Ana.
And we're in Rochester, Michigan. If you get a chance, look us up and come and see us if you're interested. Thanks.
Good night.